And we're really pleased to have Dr. Hatice Savas here to talk about updates in PET imaging for prostate cancer. Dr. Savas is an assistant professor of radiology here at Northwestern, and she has functional imaging like PET imaging. This topic is very timely, particularly the recent FDA approval of UIL PSMA compound. But obviously, hopefully, she'll cover other PET radiotracers as well. Thanks again, Dr. Savas.
Thank you so much, Dr. Ross, for inviting me again. Hello, everybody. As Dr. Ross stated, I am one of the radiologists, and PET imaging is one of my interests. And today I will try to talk about and kind of recent changes, but I will try to touch base with the other prostate imaging agents as well. So learning objectives will be to describe the current PET radiotracer to use for prostate cancer imaging. And mostly I will try to discuss with the PSMA imaging. And also, if there is a time, I would like to do some brainstorm on future changes, especially here at Northwestern. This slide was a slide I used it a few years ago for another talk. This was my first slide on that talk too. And I was, trying to give the kind of idea about how prostate cancer evolution. So it was kind of well known that time 80% of the patients will be found to have clinically localized disease at the time of initial presentation after the PSA screening. And then there will be biochemical recurrence in 10 years. Then half of the biochemical recurrent patient will progress to overt metastasis. However, when I look at right now, especially the changes in the last this year, so I think these first two sentences will change immediately in a couple of months maybe, and but the last sentence will remain present because we are toward to more highly individualized molecular imaging technologies, and it is really dramatically improving the ways that we are treating prostate cancer right now. So what were we doing for prostate cancer? It was conventional imaging, right? You were ordering a CT cap for the patient and a classic bone scan. This was specific for prostate cancer patients, but the altogether sensitivity of the bone scan plus CT cap was almost like maximum 80%. So still 20% of the time you had no idea what to do with the patients. And that's why recommendations are based on the staging, and they said these combination of CT plus bone scan should be restricted to selected patients population. Those patient populations were high risk and intermediate risk prostate cancer patient. Then recently, maybe last 10 years, there is a significant increase in usage of multiparametric MRI. So it is really great for T staging to evaluate the gland, and it may guide for biopsy, or it is, by itself, it is very valuable. But the problem with MRI of the prostate, in the pelvic nodes, evaluation is pretty limited. And also, if you want to evaluate the bone, it's a limited area of concern. That's why some institutions are using the whole body MRI just to give more promises to detect bone involvement. However, it is kind of time it is time consuming, and it's not really easy to do it. But in one of the study they did in 96 patients, they found like MRI, whole body MRI, especially was helpful in the metastatic castration-resistant prostate cancer, and they found new foci almost 50% of the patients. So we all know these facts. When there is increased PSA, there is high risk, high possibility of detection of osseous lesion, high possibility of detection of lymph node metastasis. This is our main goal when we are evaluating the prostate cancer. However, in meta-analysis studies, we did see PSA increase is not always giving us the the correct way to evaluate the bone scan. So during my residency training, I've been told always like, oh, PSA is less than 10, then this bone scan is not going to show us anything. Because based on the statistical analysis, if PSA is less than 10, only 2.3% of the men had positive bone scan. When there is increased PSA, the likelihood of positive bone scan was also increased too. Similarly, if you have more PSA, higher PSA, the likelihood of seeing abnormality on the CT was higher. Actually, this is still the same for PET imaging too. When you have higher PSA level, the likelihood of detecting lesions, number of the lesions are more. I'll show you in a minute. So because treatment is changing and individualized based on the number of the metastatic deposits and location of the metastatic deposits, this is the evaluating and finding them accurately will impact the survival. So obviously, outcomes are also progressively worse when you have more numbers of nodal and more distant metastasis. This is kind of giving us the surrogate for the tumor burden. Because we know conventional imaging plus, MRI is not really helping us too much. There was always a need for new radiotracer and specifically focusing on primary detection, staging, and recurrence of prostate cancer. So in the novel radiotracers, we used to have two groups of radiotracers. One was targeting fatty acid synthesis, and the most common, most famous one is C11 choline in this category. The other one is our other famous radiotracer, which is working on amino acid transport, F18 fully cyclovin or oxymin scan. However, recently we have a new approval of PSMA agent. There were, the European people were using it for a long time, and also there were research going on in the United States for a long time, but somehow approval was not really early. That we were kind of a little bit surprised when they give approval to oxymin but not PSMA a few years ago. But luckily now we have an approval, so it is available for everyone's use. Before starting these famous radiotracers, I just want to talk about with sodium fluoride imaging with one slide, because it is also a PET radiotracer. It is used for bone imaging, bone metastasis evaluation, because it is mechanism of action is very similar to bone scan. It is very useful for prostate cancer bone involvement. The uptake mechanism is similar, but it has better pharmacokinetics, faster clearance, and higher resolution. This is one of the image of the same patient. Clearly, the PET imaging has a better resolution, shows more foci of abnormal activity. This has a renal transplant patient, but we don't use it. Why? Because it is not covered by CMS. Although it is FDA approved, since it is not paid, that's why most of the institutions are not using it. Some institutions are using it and mostly covered on their research contract, but in general here Northwestern, we can't use it because there is no reimbursement. And I just want to touch this new guidelines for NCCN, because it is going to help us to understand the importance of the PSMA approval and how it will change our practice. So as you know much better than me. So we had bone imaging, we had soft tissue imaging, mostly CT cap or sometimes MRI. These were the two imaging modalities you were ordering for prostate cancer. Then if there was any equivocal bone scan lesion, as you know, bone scan is pretty specific but not sensitive. You can see lots of false positivity if patient has a prior fracture, although fracture is old, you may still see some activity. All that other false positives like fibrous dysplasia, Paget disease, or prior trauma related changes, you may see it. So if there was an equivocal result, then we were kind of thinking to do additional imaging, plain films, MR, correlation with other, sodium fluoride and C11 choline, etc. But now they say in the new guidelines, alternatively to bone scan plus CT cap imaging, gallium 68 PSMA or F18 labeled PSMA, which is Pylorify we are using here, either PET CT or PET MR can be considered for bone scan and soft tissue. So this is a big change, and I think this will also affect the current practice in the entire United States, because in Europe usually they already implemented this. In other the countries in Asia, they already use this, and finally we have the approval, and I think our guidelines are quickly adjusting it. I just want to touch a little bit with Ftg Pet. Why? Because Ftg Pet is our famous radiotracer. We use it almost like 90% of the time in our clinics. It is perfect for most of the cancer staging or primary evaluation, because it is very sensitive in high glycolysis. However, in prostate cancer, because the nature is more slow growing and low glycolytic activity, especially in castrate sensitive state, it is not really helpful. Why it is not helpful? Because both benign prostate lesions and malignant prostate lesions will have the same type of increased uptake, or there will no abnormal uptake at all. There might be a really high grade tumor over there. So it's not really accurate. It is not sensitive. It is not specific. It can be used. Still, there is a open door to use FDG, especially when there is a dedifferentiated aggressive metastasized prostate cancer. We all know the Envision trial, almost 10% of the patients were not PSMA positive. So that we have that 10% target population, and we have to decide what type of imaging modality we will use on this patient population. And also there are some cellular level changes in some particular the type of prostate cancer. So FDG is maybe helpful on those type of cancers. But the problem when they were trying to use FDG years ago on prostate cancer, the imaging did not add anything to the traditional bone scan or cap. That's why they said they did not add much, so we don't need to use it. As a take-home point, we really don't want to use Ftg PET in most of the cases. However, there is a small group of patients Ftg PET will be very helpful. And just a small note, if you have any incidental focal activity hotspot in the gland on FDG study, any type of FDG study, maybe you are doing for lung cancer or esophageal cancer staging, if there's a focal uptake, that has to further evaluate it, because cancer can be really hot, prostatitis can be really hot, sometimes BPH can be really hot, but to differentiate from each other, we recommend further assessment. For further assessment, there is no consensus. Some people are doing, further imaging with MRI, or some people do only PSA correlation. So let's talk about the C11 choline. This is approved almost 10 years ago, and it is kind of similar type of metabolism, but it's working on enzymes. The enzymes choline kinase are upregulated in the prostate cancer. So based on this, they were focusing on if there is an increased expression of the choline transporter, if we attach them with the radiotracer, then we will see the prostate, the cancer deposits. it was recommended in biochemical recurrence. This is very important because the insurance coverage is also very related to recommendation. So C11 call-in recommendation was biochemical recurrence, similar to Oxymen recommendation. When you had a non-informative conventional imaging on bone scan or CT or MRI, they were using it. Its sensitivity is kind of, okay, 70%, but the most beneficial part of C11 was the specificity. In this study, for example, when you do see this a small lymph node, if you are reading the CT scan of this patient, you are not going to call this abnormal because of the size criteria. And when you do see activity in this nodule in the lymph node with C11 colon, this was almost 90% metastasis. So this was very important because that time when C11 introduced, the MR was also, like a rising star. They compare it. It's a kind of small study, but they said in one of the study, they said it has 100% sensitivity. We do see every lesion in the gland, and they said may provide more accurate information in the localization of the main tumors. So I'm talking about T staging, prostate itself. So they said it is very, very useful. However, then they started doing more studies, and another study suggested sensitivity is just 66%. It is not really that much great as previous studies suggested. And because of that, we have to be careful about calling PET CT. It is not recommended as a first-line screening procedure, especially to evaluate the T staging in the prostate gland. It is not recommended. However, there is a kind of consensus. It might be used if there is a clinically suspected prostate cancer when there is repeated negative biopsies. However, in terms of staging, to evaluate the lymph nodes end staging or M staging, the bone assessment, it was pretty specific. It is almost 98, 96% specificity in multiple studies. And this is also important because our F18 was the most sensitive and specific radiotracer for bone assessment. So colon sensitivity and specificity was pretty similar to the F18-19. In terms of biochemical recurrence, it was also very useful. So this type of graph you will see in every type of imaging. PET imaging, conventional imaging, doesn't matter. When you have increased PSA, you have better detection of the prostate cancer. The most important thing, what is your PSA level? What is the like a smallest number you can detect? Right now, we are the researchers are focusing on that. So if this is very beneficial, why we don't use it? Because C11 is a cyclotron-produced radiotracer, half-life 20 minutes. You need on-site cyclotron. It is not really kind of purchasable from a nearby cyclotron because of the half-life. That's why we cannot use. That's why most of the institutions are not using it. Like a Mayo Clinic, the institution, they have their own cyclotron. They are pretty happy. Actually, because they are using C11 exclusively, they were using C11 exclusively, they had only very few Oxymen studies there in Mayo Clinic. Let's talk about Oxymen. We were so excited when Oxymen was first approved. It was May 2016, and we were expecting actually PSMA will be about to approve too, but it took like 5 years after this. And it is said it will be covered for its label indication. And label indication was biochemical recurrence. Although in our practice here, Northwestern, it is not used for biochemical recurrence all the time. We have clinicians, they are using it for primary assessment too. Why? Because they are looking for a radiotracer to help the questions which they cannot get from the traditional imaging. So because it is F18 labeled, it is cyclotron produced. We don't have on-site cyclotron. However, because it has a 2 hours half-life, it was commercially purchasable. So the company was providing us the unit dose, so we were able to use it for our patients. Just to give some information, when it was first in the market, it was about 3,600. Currently, it's almost $5,000 per unit dose. It's just a dose, not including the scan or other expenses. So this is how it looks like. The good thing about the Oxymen study, we don't have the uh, activity within the bladder. It is very helpful. Why? Because we do see it now, PSMA imaging, when there is a lot of radiotracer within the bladder, it is really affecting the seminal vesicle evaluation. And also if the prostate is small, or if there is a prior surgery biochemical recurrence, sometimes it obscures it. So we have to be very careful with the new tracer. However, in Oxymen, there is no or very little urinary bladder uptake. As you see here, distribution is very different than our PSMA tracer, and it's very different than FTG. But we have this abnormal foci of activity, and there is activity within the prostate gland, and it was a positive scan. So indication, as I said, was biochemical recurrence. But when you read the label of the Oxymen, it says if it is negative, doesn't rule out the recurrent prostate. If it is positive, doesn't confirm it. And you know, the performance seemed to be affected by PSA level, although there is no recommended cutoff to use Oxymen study for biochemical recurrence. And the during my practice, one of my biggest thing is the reading Oxymen. If it was really straightforward, it was easy to read. But half of the cases, we were all kind of wishy-washy. And if we showed the cases each other, half of them were saying, this is positive. The other half was saying this is negative. And one important thing about fluciclovin, if it is used for primary gland evaluation for T staging, the BPH and cancer will have similar type of activities. For example, in this case, there is an increased focal activity in the prostate gland and biopsy proven cancer. It was biopsy proven cancer. This one is also very hot, and the FDG, the SUV values were almost 7, very similar to each other, and this turned out to be BPH. So Oxymen was not used and should not be used for primary gland evaluation. There was no absolute threshold. We talk about it, and it is again approved for biochemical recurrence. The main limitation with this radiotracer is the limited sensitivity. It is about like 41% maximum in various studies if patient has less than 1 nanogram, less than 1 PSA. So like other studies, you know, whenever it became available commercially, they correlated with the previous most used radio tracer, which was C11 colon. And when you look at here, the light gray is Oxymen, so it was better, showing better performance compared to C11 colon in multiple different low PSA levels. So they said it is better than colon, C11 colon. This is another example from the company provided us. So there is a small lymph node, you know, that it is radiotracer avid, and it is positive. But in the real life, again, it doesn't work this way. This is the interpretation criteria. I'm not sure if you are familiar with. There's a lot of things. If it is small than 1 cm, it's different. It's more than 1 cm in the focus, you have to compare it to the blood pool and bone marrow. If you see it on the MIP images, it is high likelihood, low likelihood. It's a little bit confusing. Eventually, you'll get more experience. But one of the biggest challenge when you are doing this interpretation for me was the small sclerotic lesions. Why? Because small sclerotic lesions are known that they may not be PSMA, they may not be Oxymen avid. So we had, multiple cases. Patient has a bone scan. There are some suspicious um, rib uptake, and then they do oxymen. There are sclerotic foci, highly suspicious for metastasis, but oxymen is negative. Then you start questioning it. Is it really negative, or is it negative because of dense sclerosis? And it is difficult to get biopsy from rib lesions. So there was always like an email back and forth. Is it real or not real? And if it was feasible, we were ending up doing biopsies depending on the patient's PSA level. Um, for the flucyclovine, I think there is still a open door to use it, especially when the PSMA is negative on the cancers. But again, uh, it is sometimes very difficult to read this study. One other benefit, okay, I don't want to say negative things on one tracer a lot. One thing, it's actually very helpful for our workflow, because all of other radio tracers, you inject it and let the patient to stay maybe 1 hour or 90 minutes for uptake. This radio tracer, we inject it on the scanner, and we start imaging it in 4 minutes. So it is really easy for us to do it in our clinics. But again, so if it is wishy-washy, we were not sure how to interpret it. So let's talk about the PSMA. There's a lot of excitement in the United States because it is approved now. The whole idea was the PSMA, prostate-specific membrane antigens, are highly overexpressed in prostate cancer cells. This is kind of illustration. Normal cell, we have PSMA, but usually within the cell. For prostate cancers, the PSMAs are in the surface of the cell. So when you have a compound to go and attach to that the antigens, then you will able to show wherever this antigen is. One other thing, if you want to do the therapy, again, you can target the same antigens for treatment too. So you can label the PSMA with gallium-68 or F18. Just want to clarify this because, gallium-68 was broadly used in research areas in the United States. It's already approved in Europe, but in the United States, people were using gallium-68 a lot, not because it is a better radio tracer, but because it is mostly generator-produced radio tracer. That means you can buy your own generator and put it in your clinic, and you can start imaging the patients. But F18 labeled PSMA, the accuracy and everything is very, very, very similar to each other, but you need cyclotron to get F18 if you want to do the research studies. Right now, it is FDA approved. We can get a unit dose, but that was the reason. That's why gallium-68 a little bit ahead for the research studies. You do see lots of articles, research about the gallium-68 compared to PYL imaging, but that was kind of more easy to produce the radio tracer. That was the main reason. It is newly approved. This is important because it is also improved at the initial staging diagnosis, which is different than other radio tracer we have discussed so far. It is also approved for biochemical recurrence as well. So when we go back to NCCN guidelines, the new changes, that's why they were able to put this here, because it was also approved for the initial baseline staging. Gallium-68 PSMA 11 is first PSMA imaging agent approved in the United States in late 2020. It was little kind of weird, the approval process, because it was approved and then it's currently only available, right now it's only available in 2 sites in California, but it was approved for UCSF and UCLA. I know people working there, they spent millions of hours to get this approved. But that statement, FDA saying that it is approved for those two big institutions, but other institutions, they have the manufacturing capabilities, could produce their own tracers. That time I was kind of exploring if we can get it, here, if you buy our own generator. And I've been told, although we have our own generator, the process, all that paperwork may take maybe 2 years to get the approval from the NRC or other regulatory agent to use it here. So it was a little weird approval, but that it was a kind of telling us the other PSMA imaging is coming onto the market. It is generally, as I said, mostly generator produced. It can be produced by cyclotron too, but it is very easy to do it through the generator. That's why we have lots of data about gallium-68 PSMA. It's the good thing about gallium-68 PSMA, there was a lot of comparison with MRI too, because MRI at the beginning, when it was first introduced for prostate cancer imaging, there were a lot of also kind of inaccuracy in the reading, especially between the readers, because it was a learning curve. That gallium-68 PSMA, they started using it and started to compare with MRI, and there was a really good correlation with gallium-68 and MRI imaging, and they said it is a complementary in primary cancer assessment, especially it is better performed in a larger tumor, which is more than 5 millimeter. It is superior to standard imaging in preoperative lymph node staging in intermediate to high-risk prostate cancer patients. There are a lot of research outside, and the accuracy was almost like 90%, and it is specific. It is sensitive, but specificity is much higher than sensitivity. I have another slide I will show you, but we have to be very careful about the positivity, the location, not to overcall some other abnormalities, cancers, or other benign abnormalities. They might have PSMA expression. It is superior to conventional imaging in staging. Sensitivity and specificity is kind of higher than the CT imaging. And also it is superior to bone scan or other type of bone imaging in preoperative staging. This is one of the example, one of the study. They showed the improved sensitivity of PSMA PET compared to bone scan. This is a patient with PSA level was 500. So it is a castration-resistant prostate cancer. Patient was anti-androgenic therapy. Bone scan showed some disease, but it was limited. It was involvement of lumbar spine, maybe some ribs, some femur involvement, maybe some positivity over here. But when you look at this, it's the same patient with I think within a week they did the gallium-68 imaging. So it was significantly different, extensive osseous metastasis. So it is definitely superior than bone scan with almost 100% specificity. In terms of sodium fluoride imaging, so I was saying that it is better than bone scan. When you compare the bone metastasis evaluation using PSMA versus sodium fluoride, it is kind of pretty similar to each other. It is sodium fluoride is very sensitive, but also gallium-68 is pretty accurate to evaluate it. And also could be useful not for staging, but for response assessment. This is a kind of sensitive topic yet, but there is no consensus. But for response assessment or treatment monitoring, in bone involvement, the PSMA can be used too. In biochemical recurrence, it is again correlate with the PSA value. If more PSA value, the scan accuracy, sensitivity, the specificity will increase. But compared to colon imaging, if you remember that the numbers were like a less than 1 to 2, 3 more, some. But right now the value of PSMA level is less in the PSMA imaging, so you can detect the lesion almost 60%, positive lesion almost 60% when the PSA level is less than zero 0.5 in biochemical recurrence. In terms of lymph node metastasis, as you know, we have size limitation on conventional imaging. So if for the PSMA imaging, if you have a intense activity in the lymph node, no matter the size is, it is positive. It is very high accuracy for evaluating a small lymph node. This patient's PSA level was I think 0.9. So they detected it. They did the surgery, the treatment, and after that the PSA value was 0.07. So one thing about, we also discuss in our clinical practice, if you have a focus of increased uptake in the bone, but if the CT scan, correlative CT scan is negative, still they say you probably should trust the PSMA imaging because you may not see any change on the CT scan in early cancer, but eventually you may see sclerosis. We do see this in breast cancer a lot. Sometimes we do see FDG activity in the bones, but there is no corresponding CT abnormality. However, in the follow-up imaging, we start seeing that treatment-related kind of sclerosis area. So whenever we use the F18 FDG for breast cancer, doesn't matter the CT correlate, we usually call it. So it is kind of similar to PSA imaging. So in this one, actually, this is the early set of imaging. There was increased activity, nothing corresponding on the CT, but patient did the treatment. So on the 6-month follow-up, the sclerotic focus appeared. So the PSMA was actually accurate compared to the CT imaging. So performance of MRI and gallium-6 PSMA PET MR was higher in high risk versus intermediate risk patients. I have another slide for that. We all know the T staging right now, the recommended modality is MR. The lymph node and bone is PSMA imaging. However, if you have a capability of doing MR and PSMA imaging on the PET MR, actually that is probably the future direction for the imaging. Then you can have accurate T staging plus accurate N and M staging. So this is one of the study the Australian group has published a lot. Dr. Hoffman, is very famous in prostate field. So they were evaluating the utility of gallium-68 in detection of metastasis disease and high risk in advanced prostate cancer. So the conclusion was the low PSA level, the biochemical recurrence, when you use the gallium-68, although it is low PSA level, it is very accurate. And when you have a little bit more PSA level, accuracy will increase, sensitivity and specificity will increase. So it is similar to the other imaging agents, but when you start seeing them like almost less than 0.5, almost 50% cases turn out to be positive. So it was their prospective randomized multicenter trial pro PSMA study. I just wanted to show this how they randomized the people. They selected the people. They were looking for diagnostic performance of PSMA PET versus conventional imaging. What they did, they looked at high risk and intermediate risk patients, and they put one group of patients in randomly in CT plus bone scan. The other patients, they put it in PSMA imaging, and then they followed the patient and they did serial imaging. Approximately 300 patients were involved in the study. So what they found is the PSMA accuracy versus conventional imaging was 30% more. And based on this imaging findings, almost 30% change in the treatment plan. So this is really kind of interesting because this is a prospective randomized trial. So this is something I think we are kind of going through the same path right now. It will change our management a lot too. And one other thing, the study noted that PSMA imaging was much likely to produce inconclusive results or equivocal results. It was only 7% compared to the 23% by conventional imaging. They did lots of studies comparing PSMA imaging with fluocyclovine. So this is head-to-head comparison, only 10%, 10 patients involved. But one thing I want to show here is 50% patients were negative on fluocyclovine oxygen scan, but they were positive on PSMA scan. They suggested that superior detection rate on PSMA imaging than fluocyclovine. Because it is 10 patients, you may not really feel comfortable. Actually, this is one of the image examples. So these two small nodules, they are pretty small here. They were negative on fluocyclovine oxygen scan, but they were positive on PSMA scan. They did another study. This is prospective head-to-head comparison, phase 3 trial. They compared fluocyclovine with gallium-68 PSMA imaging, 50 patients. They scanned the patient with both radiotracers within 15 days, and if there is an uptake, they call it positive. There is no biopsy correlation. So obviously, the detection rate were significantly lower with oxygen study compared to PSMA. It's almost like a doubled. And pelvic lymph nodes was much more detected by PSMA imaging, and extra pelvic lesions were detected by only PSMA imaging. And one other thing, actually, it's kind of really grabbed my eyes, was that reader agreement. Reader agreement for PSMA PET CT was significantly higher than for oxygen study. This is one of the things that really important for us. As I said, if oxygen study is straightforward, we are calling it. But if it is like intermediate, we all have different opinions. Although all of us like have enough experience how to read the oxygen studies. This is also another study published. Actually, this is based on the SNMMI and EANM recommendation for prostate cancer. So the staging and during PSMA-directed radiotherapy, so PSMA imaging is very, very important. If it is low PSMA expression in target lesion, you can't do the treatment. In advanced stage, mainly in the metastasis, mainly in the liver, the cancer itself can lose PSMA expression. This is also important when we have more experience with PSMA imaging. If we start seeing patients, like living longer with better treatment, but eventually there might be sensitive, PSMA imaging may lose the receptor sensitivity. Kind of, I'm thinking similar to our iodine imaging. At the beginning, the cancer might be so sensitive to iodine, but eventually they may use their differentiation for iodine. So maybe eventually we will start seeing this too. So let's talk about the other PSMA imaging, the current one, Pylarify. It's the second generation. Whatever I talk for gallium-68, actually it applies here too. Sensitivity, specificity, it is very, very close to gallium-68. They did comparison head-to-head comparison. All suspicious lesions detected by gallium-68 was also detected by F18. So that time it was 2015. They said it might be alternative to gallium-68. Actually, it is the same. It's not, alternative. Maybe a little bit, I don't know, a little bit better in terms of detection rate. It is for primary cancer detection using the PYLARIFY F18 PYL imaging is kind of 50-50. Some studies say it is really good, but some studies say it is not. There is overlap between BPH, but during our study here with PYL imaging. With our experience, if you have a kind of delayed imaging, you will see the lesion better. So I think it is kind of really comparable with MRI. This is my personal opinion. It is not really lower than multiparametric MRI. It's pretty comparable, and especially high-grade lesions. I think it may be usable for future. So this is just an example, the prostate cancer, BPH, there was no radiotracer activity, but the prostate cancer, there was an increased radiotracer activity. Its sensitivity and specificity is very, very similar to gallium-68 imaging. It is definitely superior than conventional imaging. And actually, in this study, they found 50% disease in the cases in the lymph nodes less than 3 millimeter. So this is a big thing. If you can identify 3 millimeter lymph nodes in the pelvic cavity before your radiation treatment, so it may change your the coverage. So it is very important. It is definitely superior to conventional imaging. This is, again, another example with small lymph nodes. You would never, ever call this abnormal on CT, but on the PSMA imaging, it is positive. So in terms of bone metastasis, the sensitivity and specificity of PYL is definitely higher than bone scan. So one thing I just want to emphasize, sometimes the discrepancy may be coming from misinterpretation. This is one of our case. This was read as a normal scan. They said there is no scintigraphic evidence of metastatic disease. This is patient's PSMA study done here. There's extensive metastasis. Actually, when you look at this study, you don't see the kidneys here. This is called a super scan. Actually, this means when you have a super scan, it means that this patient has full metastasis in the bones. So sometimes because of interpretation error, we have to be careful about the interpretation too. It is superior to conventional imaging and biochemical recurrence, and it is superior to other imaging modalities like other radiotracers. When it has a low PSA level, it is very successful. Early detection, when you have a local recurrence and lesion outside the prostatic foci, you have more detection when you have a higher PSA, similar to other imaging choices. And this is one of our case. The lymph node was really small, and there are actually several lymph nodes, 1, 2, 3 lymph nodes, but only one lymph node was radiotracer avid. So that was that was the metastatic one. So this is a very good study. They looked at the PYL uptake in the post-prostatectomy patients. Those are considered for salvage radiation therapy. This is a prospective trial just published April 2021. So their conclusion was actually doing this treatment, the imaging has changed their radiotherapy inclusion. It changed it. So these type of studies we should look more, because changing management is a big issue right now in after PSMA imaging. One of the other studies showed that after PSMA imaging, they changed the plant management almost 21%. One issue, false positivity and false negativity on PSMA imaging. In any type of imaging, we always have false positivity, false negativity. In the PSMA specifically, this is a nice, like imaging pitfall article. They looked at the false positive and false negative ones, and they concluded that uh, false positivity in biochemical recurrence is was less than 10%, and most of the time it was in the prostate bed, and it was mostly in the radiotherapy patient, prior radiation treatment. The patient had prior radiation treatment, so there might be some inflammation going on, and the PSMA shows positivity. And false negativity was mostly due to small metastasis, small size metastasis. This is a very nice article, review article about false positivity and actual false positivity. When you look at this, lots of benign lesions, lots of malignant lesions showed PSMA positivity. One hot topic right now is gliomas. Actually, there is a big research going on right now for a PSMA on glioma detection and PSMA for glioma treatment. But when you look at this, almost all type of cancers may have PSMA positivity. So what does this mean? That means if you have an unusual site of PSMA activity, or if it doesn't fit the expected imaging finding, we should be careful. For example, in this scan, this is the one of the case from Dr. Hussein. You see there is an increased uptake. This is definitely a positive scan. But when you look at the CT portion, this patient has an emphysema. Apparently, he's smoker. And also, this lesion is a spiculated lesion. It's going to the pleura. If you do look at the CT, this is a primary lung cancer, period. So, and primary lung cancer can express PSMA. This, we call this metastasis. It was one of our early cases. Actually, this is 99.9% the lung cancer case. One other topic is ADT impact on PSMA scan. So there are two different opinions on that. But the accepted opinion, from my understanding, is the the long-term ADT significantly reduces the visibility of the castration-sensitive prostate cancer on PSMA PET CT. And we recommend referring patients for PSMA PET CT before starting ADT. This is a European Journal of Nuclear Medicine study. And actually, the consensus statement on PSMA PET CT in Europe, they said potential flare on PSMA after ADT treatment can be seen. That's why if patient is on ADT treatment, you have to wait 3 months to scan the patient at the initial timing between the ADT initialization and PSMA scanning. And one study they did with 15 patients, they saw like a SUV max decrease in the hormone sensitive patients. And on the 7 patients were castration resistant, and they said increase in the castration resistant prostate cancer. This is also a new study. So because of that, I think the concern with ADT is very valid. And that's why they say the ADT PSMA imaging either should be done before ADT initiation or maybe 3 months. This is not a consensus. This is just a recommendation. Maybe 3 months after the ADT. One of last week, Dr. Bridwell was here. He's an advisor for Pylarify imaging, and he was also suggesting at least 4 to 6 weeks after ADT. And if it is possible, should be done prior to ADT. So is there anything for SUV max cutoff? We love to look at SUV, especially clinicians are asking us what is the SUV level, but the number is not really everything in PET imaging. And similar to prostate cancer, this is one of the study they came up with the 5.3. I don't know, that I'm a thoracic imager also. there was a study when first FTG introduced for lung cancer, they were saying the 2.5 is the cutoff, but I have seen tons of positive cancer less than 2.5 or no FTG avid cancer. So we have to be a little bit careful about the SUV numbers. There needs to be, we need more studies to do that. In terms of response assessment, this is very hot topic also. On the consensus statement on PSMA PET in Europe, they were suggesting maybe we should say that responders versus non-responders. So non-responders will be the progressive disease, responders will be the others. So there is, again, still no consensus, but the one thing they said, if you want to use PSMA for response, you have to get the baseline PSMA just to compare it. PET-MR, as I said, is a novel technology. Only few institutions have it. One is Northwestern. It is simultaneous acquisition. You will have really nice MRI imaging plus PSMA PET imaging. That might be the best future combination. It is one of our case with high radiotracer activity in the lesion here, but this one, the bone lesion was missed, and this tiny bone lesion was missed on the MRI, but we detected on PET portion, and actually it changed the management a lot. So this is one of the study, very interesting. They showed 5-year trends of bone scan and PSMA, and retrospectively in a private center. So this is the performance of the exam. They performed almost 3,000 studies, and almost 2,500 was a PSMA and little bone scan. So this is just for urologist pattern. They didn't look at oncologist, radiation oncologist, medical oncologist pattern. But you see here, this is the PSMA, how there's a big slop here compared to bone scan. There was kind of really, less, there was a less interest in bone scan. In the 6 months after PSMA PET, there was almost 50% decrease in the numbers of bone scan performed in that institution. So I don't want to go through that much oligometastatic disease, polymetastatic disease, but the concept is like tumor burden, if less tumor versus like a widespread tumor. But the thing is, it is a the big topic right now. So if you have a better detection of the lesions, if you say oligometastatic versus polymetastatic or vice versa, there is a big change in treatment. So PSMA imaging, actually, we have to be ready for this change because of the sensitivity and specificity of PSMA imaging. They say if the scan is negative, it is very valuable in low risk patients, especially if you are going to perform radiation treatment in a patient. So if it is negative, you can trust the scan. One other thing that they want to make sure, the sensitivity. The sensitivity is affected by the lesion size. If it is small lesion, obviously that you may not see the radiotracer activity well, but in terms of lymph node detection, the PSMA imaging much more sensitive than CT or MRI. I just want to skip this one. So current issues, I have few slides left. Current issues is one of them is the cost. And we know PET CT or PET imaging is currently more expensive than the CT plus bone scan. This is just to give you some idea about the cost. Again, these are just the radiotracer costs. I'm not talking about the scanner cost or like a technical fee, other things. But PSMA is 400 to 600. The oxymin is about 5,000, and FTG is almost 100 bucks. But bone scan is less than 50 bucks. So, we have to really work on this too. And reimbursement wise, private insurances were kind of really good. Medicare was a little bit resistant to pay for baseline assessment. As you know, the PSMA is still, PYL is still not the pass-through coverage. We are expecting it in January 2020, which will help us to get at least some revenue from it. So one thing about the PSMA, there is a lot of radiotracer activity within the bladder. It affects the evaluation of the salivary, the glands related to prostate. I forgot now. But there is a radiotracer PSMA 1007. Actually, it has a hepatobiliary excretion, and it will not go to urinary bladder a lot. That's a good thing. And one other thing, PSMA detected metastasis may lead to decision not to treat the primary tumor if we have a lot of positivity. Maybe it may cause unnecessary additional investigation and delay in the treatment. Maybe rib biopsies, we will perform more. And in terms of the participation of the clinical trial, we have to be really careful about it. And in economic scale, as I showed you, it's a little bit expensive. So we have to be cautious before ordering the scan. We are all excited. But sometimes if there is no added value to the management, maybe we should not order this study. And the one thing that 3 months was the recommended interval from the European site for ADT. And specific clinical scenario, we have to be careful about the oligometastatic versus polymetastatic disease. And sometimes PSMA PET comes with the incomplete information because of the lack of histology genomic data. We have to be really careful about it. And I think the first conclusion we can make is that increasing use of advanced PET imaging has led to the increased detection, but we have to be careful. We did this type of, dilemma when first breast cancer screening came to the, the clinical use. Lung cancer screening, when we start doing lung cancer screening, we start seeing all that tiny nodules. We're not sure what to do with them. Maybe at the beginning we will have some hesitation in the PSMA imaging. That's why I just made it up. It's not from anywhere. That's why maybe we should propose something, how to use the PSMA tracer in daily practice. Maybe it's a kind of, we can say this is Northwestern experience, Northwestern recommendation based on the PSMA positivity and location, the number of the abnormality, because PSMA treatment is coming. So we have to be really full prepared for it. And few last words, just this is my last slide. Molecular imaging really is very promising technology, especially in the prostate cancer world. And PET imaging is really complementary in the primary T staging to evaluate the gland, but it is way better than conventional imaging for initial staging and biochemical recurrence. And I think the PSMA targeted agents are changing the game right now, and they are superior to our previous competitors, C11 and Oxymin study. And again, a novel treatment is about to start, PSMA receptor positivity, lutetium PSMA. We were a participant for Vision trial, and I hope we are going to start compassionate use of the lutetium treatment too. Thank you so much. Thank you so much for your time. And I think I exceeded the time a few minutes. Sorry about that.
That's okay. That was a great talk. Does anyone have any quick questions?
Hatice. Hi, Hatice. Great job. This is Tim, nuclear pharmacist. And
hey,
I did want to point out one thing, and you had mentioned, and unfortunately, we are in the business of healthcare in the scope of trying to optimize margins and generate revenue. And unfortunately, right now, with PSMA not being, or Plerify specifically not having pass-through status, we did run an initial report. It is limited data because we only did a very short time frame. So we had 50 studies that were evaluated in terms of the revenue captured. And based on the revenue compared to just the product cost, we are negative over $60,000 for those 50 studies. Now, 54% of them happen to be Medicare, which Medicare is only reimbursing for the PET portion, not the drug itself. So just to put a little perspective, obviously after January 1st, when it gets passed through status, that will significantly change. But for the time being, that's the state we're in. So just wanted to give that information.
Thank you. Thank you so much, Tim. Tim is our manager in nuclear medicine. He's the pharmacist, and actually he was one of the main person to bring the PSMA imaging to Northwestern. Thank you. Dr. Catalano, actually, I think he has a question.
Yes. So I have a patient who has, high PSA and locally advanced disease, and he had a PSMA PET, and there was nothing in the prostate, there was nothing in the lymph nodes, and he had a tiny lesion in a rib. So how likely is it in that setting that it was an avid lesion, PSMA avid lesion? How likely is it that that's metastatic?
Thank you so much. It's a great question. Actually, we were just talking about this with Dr. Ross a few days ago about our kind of research, one of the research topics. So actually, we should learn a lot from the PSMA imaging. So it is really less likelihood of having one rib lesion, positive rib lesion, and nothing else, especially nothing else in the pelvis. We do see those cases. We did see those cases in Oxymin studies too. So if it is positive, I think if it is the only lesion, first we have to think about the false positivity maybe. But I know from the clinical practice, depending on the PSA level, maybe you guys will end up to do a biopsy if it is amenable for biopsy. So, but probably from my perspective, the best thing to do a follow-up imaging. Because we know some of the cancers are not PSMA avid, but just only one rib lesion, likelihood of being prostate-related metastasis is pretty low if there's nothing else. Dr. Hussein is gonna say, and Dr. Hart. So I think you guys just jump on the discussion.
Sure, maybe I can go. So I think, Hatice, you've done a fantastic job. I think there's a lot for us to learn. And I do think that the critical part from my perspective is to be more cautious about the overall picture rather than just a believer, because you and I have shared several cases when a PSMA in a rib abnormality changed after time. Another patient we biopsied turned out to have multiple myeloma. The other gentleman that you just saw with the lung cancer, I do think that's going to be the critical part. But the other part, I think, clinically, is the issue of covering the cost, because my understanding is that Medicare or insurance right now is only covering the PSMA based on the FDA approval for detection, but not for sequential follow-up on therapy. Is that the case?
Yes, that's my understanding too.
And so that's going to be a hard thing because exactly I have a case right now where conventional imaging is completely normal. The PSMA is the only imaging that's showing multiple areas of abnormality. I might have reached out to you about him. And the issue comes up, if I'm going to treat him, how am I going to monitor response? We can check PSA and all of that, but how am I going to assess the disease? That's the hard part.
Yeah.
My question had to do with the local detection. You were talking about the difficulty of seeing the seminal vesicles, and I assume the base of the prostate too, because of the bladder uptake. Would it make sense in those patients where we're considering or where we're concerned about that to catheterize them so that you get as empty a bladder as possible?
Yeah. The thing is, because this is a radiotracer, it's a radioactive, it is not really widely used to catheterization of the patient. That same thing was used thought for cervical cancer patients, that it is also blocking, and some institutions were using it, and it became an issue for contamination and other things. What we did for our clinical trial here, we recommend the patient to, go to the bathroom before the scan. However, because it takes too much time to scan the patient, and also these patients, especially for initial assessment, if a patient has a big prostate, some like a blockage over there, it is sometimes difficult. You have to really window, but catheterization, although it seems reasonable, I think in daily practice it's not going to work. It's going to add too much additional thing, and it will increase the contamination and on the scanner. And I don't think it's really a feasible thing. The best thing to have a radiotracer and not go through the renal collecting system, go through the liver, and they will not go to bladder. So that is the best radiotracer. They are working on it. There is some improvement. Yeah, that's I think that my answer. Dr. Katal and Dr. Hussein, I think you could just jump.
No, I'm done. I
Sure.
already, you answered my questions. Thank you.
Sure. And Dr. Catalano, you are?
He just likes keeping his hand up.
No,
Okay.
I think I just learned that we have to lower our hand, so we just lowered it.
Sure. Okay.
Well, thanks a lot, Dr. Savas. It was, again, a great discussion. And everyone, thank you for staying late. Have a great night.
Thank
Thank
you.
you.
Bye-bye.
Thanks.
Thank you. Bye-bye.